This
I did
conference will
try it
now
over the
be
weekend.
recorded.
I did try it over the weekend and recorded myself, and it worked.
Okay, I thought that's why you might have done it. So we're in good shape. So we are recording, and I'm going to call off the checklist I've been busy writing here. Starting with Jake Lechelderoux, Professor Bill, who we are delighted to welcome back. Rich Jackson, Ron Boucher, Sylvester Mann, Dennis Correa, John Appler, Jim Ward, Ken Anderson, Paul Frieda, Peter Capra, Carl Foreman, Larry Fish. Have I missed anybody?
You missed your co-moderator.
Len, I didn't put you on. You're right.
I don't think so. Yeah.
No, thank you very much. Okay. My gosh, excuse me. Okay. Now, Ron Boucher, have you ever been with us before?
No, I'm a first timer from Sunnyvale, California.
Super. Ron, under normal circumstances, you would be up first. But we're going to make a slight exception in deference to Professor Bill because I happen to know that Bill may not stay awake for the whole of the meeting. So,
Rick, I'm
yes.
sorry, Bill, or Rick, can I interrupt? Why don't you go ahead and let Ron go first? I'm feeling pretty good. I think that, you know, it might be better to keep the usual sequence. So I'll hang out and we can talk about Ron and then I'll go on.
Are you sure?
Yeah.
Okay.
Just so you know, Bill, if you fall asleep, they will talk about you.
Okay.
I found that out the other week.
Well, I'm going to count on somebody to shout into their microphone to wake me up.
All right, well, we're charging Len with the responsibility of calling you on your cell phone if we don't get an answer.
Okay. Fair enough.
Okay. All right. Well, in that case, Ron, we will stick to our normal routine. And what we usually do is we welcome all our new participants. So welcome to you. And if you feel up to it, we would like you to tell us a little bit about what brings you to this call, how you found out about us, a little bit about yourself, your age, where you're treated, your disease demographics, and how you think we might be able to help you. Given that you've told me already that you're from Sunnyvale, I have some suspicions as how you might have heard about us, but I have no advance notice. So please go ahead.
Okay, you want me to take about an hour and a half or what?
We usually spend half an hour, 40 minutes with, it depends how many people we've got, but take your time and leave it to us to moderate if we feel we're going too far along.
Okay, I'm going to try to go fast. With regard to how I found out about you, I can't even remember. There might have been something in my email inbox, and then I went snooping around, and I don't know. I got in some message room, and I think one of you gave me a heads up on this particular call. Can't remember.
Okay.
Sorry. But anyway, I was diagnosed in 2006 at age 54 with a Gleason 7, and I had a prostatectomy shortly thereafter, which put my cancer in remission for about a year with undetectable PSA. And then when I started having PSA readings again, I had IMRT radiation about a year and a half after surgery, which gave me another 7.5 years of remission. And then a couple of years ago, I started having PSA again. And so I went to my third treatment plan, which I call the triple elephant gun. It was a combination of Taxotere, the standard protocol, over 18 weeks, 6 infusions, and then additional radiation of the lymph nodes that head up toward the chest cavity, and Lupron. And since that treatment plan, I've been in remission again. So I'm hoping for a much longer term remission this time. And I'm fortunate to have a really good team of doctors, both locally here in the Bay Area, and I consulted with Mark Scholes down in Marina del Rey, and he's the guy that came up with this most recent treatment plan. I also attend the Silicon Valley US2 support group that meets at El Camino Hospital in Mountain View, and I try to attend that on a regular basis. So, I come to these forums both to share my experience and to learn more about advanced disease, since I'm in that category.
Okay. Well, I actually suspected that somebody may have, Jim McCoy or somebody like that might have told you about us at El Camino. That was my guess. I wasn't right, but I was close. There's a few guys in that El Camino group that know about us, and Peter, who, let me see, are you on the telephone or are you on the, no. So you can see Peter in the bottom in the middle there, and Peter has attended that El Camino group several times, right, Peter?
Probably three times.
Right. So
Yeah, I thought he looked familiar.
yeah.
Yes.
Yeah.
I'm the guy that came from Hawaii, was being treated at UCSF.
So,
Aloha.
so who's your local treatment team, Ron?
My oncologist is Shane Dormady, and my radiation oncologist is Robert Sinha.
Okay. So Dormity is right there at El Camino Hospital, isn't he?
Yes.
Yeah. So, I mean, it sounds like, and by the way, Peter also happens to share Mark Schultz with you. Well, actually, that's not true. He shares Jeff Turner. He shares the practice, but he sees Jeff Turner rather than Mark Schultz. So, so as a somewhat similar. So, do you have any specific questions for us? Otherwise, I want to open it up to the guys to maybe have some discussion with you.
I don't really. I just came with my ears on.
Okay. Well, that's good, because there's usually a lot of good information that's generated. And by the way, we do record these calls, and so you can listen to this call or the old calls. Best place to find them right now is on our YouTube channel. You can also find them on our website. But it's a brand new website, and I'm not exactly sure how to find them on the website yet, but I know they can be found there. I have to brush up on that. What was your what sort of PSA history do you have? How high was your PSA, and how fast did it move when your disease came back?
Yeah, so my cancer has been aggressive from the start, but it's also responded well to treatments. When I was initially diagnosed back in 2006, my PSA only got to like 5.8. I believe that a year earlier, they probably could have detected the cancer, because my trajectory went from 1.2 to 2.4 to 5.8 over a period of about 3 years. And so then it immediately dropped to undetectable when I had the prostatectomy in March of 2006. And then when it recurred, it went from 0.12 to 0.20. And when it hit 0.20 is when I did the radiation.
Mm-hmm.
And then that made it undetectable for 7.5 years. And then a couple of years ago, it went to I don't think I have the numbers exact, but it went to 0.03 a couple times, and then 0.04, and then 0.06. And when it reached 0.06, it was doubling about every 6 months. And since I'm planning to live to my 90s, I've decided at the beginning of my diagnosis, actually, that I would use every tool in the bag along the way. And since practically every treatment I've ever heard of works better the earlier you have it, I decided not to wait around. At first, I was going to wait to be eligible for Dr. Almeida's imaging down in Phoenix.
Right.
PET scan. But then I thought, well, geez, do I want to, give this cancer another year or two to grow before they can see it? And the answer to that was no. And so that's when I went to Mark Scholes. I'd seen Dr. Scholes speak at the PCRI conference a couple times, and he seemed the most knowledgeable about using drugs to treat cancer. And at that point, I was kind of resigned to the fact that even though I don't trust drug companies, I was resigned to the fact that I was going to need some chemicals. And so that's the main reason why I went. Well, that plus the fact that a lot of guys in the Bay Area had gone to see him and gave him great praise, and I saw him speak at PCRI. So that's when I made an appointment with him, and he came up with this plan.
Okay, and I'm assuming, I shouldn't assume, was your Gleason 7 a 4+3?
Initially, the biopsy was 3+4, and the pathology on the surgery was 4+3.
Okay. All right. So, I mean, I think you're a great addition to this call, because we have a lot of guys on the call who do not believe in early intervention, and especially early use of chemotherapy. I personally tend to think the earlier the better, as many of the guys know. And it's great to have somebody with us who has intervened early. So I'm going to throw it open to some of the people that are on the call and see if they have any questions for you. Anybody like to open the discussion with Ron?
Sure, I will. So it sounds very similar to my situation, although I didn't do chemo treatment, but I did do proton beam down in San Diego for 2 metastatic lymph nodes that came back. I had prostatectomy, I had IMRT and so forth at UCSF. How did you determine your spread? Did you do a gallium-68 scan? How did you know you had lymph nodes in your abdominal area?
I did not. My cancer has never been visible on any scans that I've had. We concluded that I still had the cancer simply because I had PSA after my prostate removal. And so the logic that Dr. Scholes used was, well, we know you've got cancer somewhere. We have no idea where it is. So let's do the Taxotere, which should kill tiny tumors no matter where they are in your body. But for the tumors that are too large for the Taxotere to handle, the most likely place for them to be is in those lymph nodes that head up toward your heart, because that's the favorite place for the prostate cancer to go after it goes outside the local area. And so he described it as the growth of prostate cancer as, it sends a few soldiers out to establish a new camp, it builds up the camp, and then it sends more soldiers out to build new camps. And so that sounded pretty believable to me. And so he said, did you have radiation of the local area back in 2007? And I said, I don't remember. So he said, give me the phone number of your radiation oncologist. So he called up Dr. Sinha, and they had a nice conversation within a couple of minutes. And Dr. Sinha said, no, he had not radiated the outside of the original bed the first time I had the radiation. And so Dr. Scholes said, well, we can radiate more lymph nodes. So he worked with Dr. Sinha and Dr. Dormady on this treatment plan, and they all agreed on it. And Dr. Sinha said, well, I'll radiate the lymph nodes up high enough where I'm not going to take a risk to your other organs. And we'll see what that does. And so that was the logic behind the treatment plan.
Mhm.
Yeah, well, I would agree with the thinking. With my situation, I knew something was on the move, so I went for a gallium-68 scan at UCSF, and sure enough, that pinpointed two metastatic lymph nodes in my abdominal area, lower abdominal, and I chose to hit those with proton beam. But so that's, I'm sitting here, maybe as I mentioned in the last meeting last week, maybe the shoe will drop again, and I'll hit it again, goes up again, but I have a little more aggressive disease than you do, or a lot more aggressive disease, but but I think you're on the right track. It seems like you're doing sensible stuff.
Yeah, I'll make a comment on comment made earlier. I in my opinion, I mean, I try never to tell people what they should do, but in attending a lot of support group meetings and seeing a lot of survivors over the past several years, my thinking is that the optimum approach depends on a lot of things, but one of the things that isn't mentioned often enough is your age. And in my opinion, being diagnosed at age 54 was 180 degrees from being diagnosed at age 75. And that's the reason why I've decided to be very aggressive every step of the way, because there aren't any long-term studies that on this disease. The longest term is like 10 years, maybe, if that. And so someone who's diagnosed at a young age, to me, that's a whole different deal than being diagnosed in your 70s. And so that was part of the logic of that, plus the fact that I've worked in customer support my whole career, and I understand how important it is to prevent problems and have contingency plans and so forth. So I just wanted to throw that out there, because in the support group meetings that I attend, it's unbelievable how rarely age is brought up when considering different treatment strategies. And to me, it's the most important variable amongst all the 125 variables.
Who else would like? And by the way, on that issue, I think age is an important factor, and I know we certainly consider it on this call. And I was also diagnosed at a young age, and it factored into my thinking as well. Who else would like to say something to Ron? Jake. Yes, go ahead.
Go ahead. I'll go after Jake.
Hi, Ron. Just welcome to the call, first of all. Second of all, Rick mentioned our YouTube channel with historic videos. I pasted a link to it in the chat box. Hopefully you'll see it to the right of your screen.
Oh, great, thanks.
Okay, and you can see pretty much all the recordings that have been made over the last 3, 4, or 5 years. I'm not sure how far they go back, but
Great.
It's just for your information.
Thank you.
Yep, you're welcome.
Hey, Ron.
Oh, go ahead.
Oh, sorry,
Ron,
was that you? Was that you, Len, that wanted to come in before?
No, it was
before,
Bill.
but just
Let Len go.
Len's being rude.
oh, I'm sorry. No, go ahead, Bill. You go.
Ron, do you have a family? You know, one thing to think about when you are diagnosed as young as you were is, do you have a family history of prostate cancer or other types of cancer?
No, there's no family history of prostate cancer, but I do have some cancer in the family. I had an uncle who had testicular cancer, an aunt that had both ovarian and breast cancer, and a grandfather that had skin cancer. By the way, I've also had skin cancer. I had melanoma and two cases of squamous cell carcinoma, all of which fortunately were caught early enough to be curable.
Okay, so I would, you know, I was thinking about the potential utility of genetic testing, but I don't think that, you know, that it's without having more first-degree relatives that have had either prostate cancer or ones that are related to it, like breast and ovarian cancer. The relative that you mentioned, I think, was not a first-degree relative. So I don't think that genetic testing probably is warranted, but
Yeah, actually, back in 2000, at the end of 2007 was when I had my second occurrence and melanoma around the same time. And I did get genetic testing back then.
oh, okay,
And it was for the BRCA1, BRCA2 mutation. And
okay.
I was negative on both of those.
Okay, yeah, and I forgot that you said that you had melanoma, which is in the constellation of cancers that are triggered by BRCA mutations. It might, but now that I'm thinking about it a little bit more carefully, there are several other mutations in the same pathway as the BRCA genes, you know, that could come into play. These are genes that are called ATM and ATR and, you know, a bunch of others. It might be worthwhile talking to, if you have ready access to a genetic counselor, talking to a genetic counselor to see if testing for additional mutations in additional genes is warranted.
Yeah, you know, I've thought about that. My thinking on the genetic testing is, one, it's a rapidly evolving science, and so the number of tests continues to increase. And the other is, at this point with my situation, I think I'm probably more interested in the genetic testing on what treatments will work and what treatments will not work, as opposed to, you know, learning more about my particular disease. Because, you know, like I said, my disease has been aggressive since I got diagnosed, but it also has responded nicely to treatments. So, you know, I'm sure the profile of my disease could change, but I'm not sure what I would do differently if I found out that I had mutations that made me more susceptible to having prostate cancer. But when they have tests that help determine whether or not I would benefit from a treatment, I'd, of course, be extremely interested in those tests. But I'm not sure there's any of those available.
Do you want to take that one, or should I?
Oh, you're talking to me?
Yeah.
Yeah, no, you can go ahead. You can take it.
Okay. So the tests that exist are going to tell you what exactly that right now. They're going to identify the mutations that can be addressed by certain of these personalized medicines. What I think Bill is suggesting is that you start off by looking at a comprehensive germline test, which will look at potential mutations you may have inherited. And by the way, Ron, there is an excellent webinar on our website. I think you can look under webinars that Bill gave to us. How long ago was it? About 2 months ago now, Bill, right?
Yeah, approximately.
Yeah. We should probably tell you that Bill has been a career cancer researcher at Roswell Park, which is one of the NCCN hospitals. And as he'll tell you shortly, has actually been treated with two of the drugs that he has researched. And I would strongly advise you to listen to that webinar.
Great.
One easy way to find it, because I just did that, is if you put Bill's last name, which is Burhans, B-U-R-H-A-N-S, in the search window at the top of the page, the webinar will pop up right away. I think it's called Cancer Genomics 101 or something like that. So there are a couple of tests available. The color test is one, which is a very easy one to access. Tests for about 32 or 33 mutations. It's a spit test, and it's not that expensive. You need to be a little bit careful because when you go straight, first of all, to color.com, that test will not appear. You have to maneuver to find the cancer genetics test. But that will give you about 33 and does not require that you meet with a genomics counselor, but does give you the option, and they will connect you to a genomics counselor, I think at their expense, if I'm not mistaken. The other test that we often see used, which is the one Peter did, is the Ambry genetics test, which has to be ordered by a doctor and has a lot more options. And then separate and apart from all of the germline tests, you can also have your tumor sequenced if you've got identifiable tumor material, which you may not have. And that is looking for what they call somatic mutations, which are mutations that your body has made itself. And those mutations are not going to appear in every cell in your body because you didn't inherit them and they weren't part of your original genetic makeup. But over time, certain cells have mutated and have produced those mutations, some of which could be the same as what you might have inherited. They just came from a different place, but they're still the same type of mutation, and you would still use the same type of drug to address them.
How long can it be after the tissue is removed from the body to do those tests?
That's a good question. We, on this call, we try to encourage men to get very recent tissue samples. The reason being that prostate cancer in particular has a propensity to mutate, to morph, I should say. So what you see from 3 years ago might not be what you show today. And somebody in your situation probably doesn't make a lot of sense to do the somatic testing because you don't have enough tumor material to make it worthwhile. So for you, the best starting place would either be color or Ambry genetics, just to verify. And as Bill pointed out, the fact that you've got prostate cancer and melanoma, there is some relationship there, and it might be worth doing. It's not a very expensive test either, $249, I think. So they might be something to think about. But let's keep moving along here because I know a couple of other people wanted to talk to
Rick,
you.
can I just add a few more things?
Yes.
Okay, first of all, Ron, actually, the guidelines put out by the NCCN committee that creates them, which is the chair of it is actually one of my oncologists, suggests that anyone with advanced prostate cancer should be genetically tested. I blanked on that earlier when I was talking about this. And second of all, the additional mutations or genes that could be mutated are in the same pathway as the BRCA1 and BRCA2 genes. They're a class of genes that are involved in DNA metabolism. And if you have mutation in one of those genes, then you would be potentially sensitive to a drug that's in a class of drugs called PARP inhibitors. And the first one in that that was created in that group is a drug called olaparib. But there are more recent additions that are more effective. So it is possible right now that that there would be personalized medicine type drugs that could be beneficial to you. So I would, I would strongly encourage you to get germline testing.
Thank you.
Len, you had something, so let's go to you next.
Yeah, Ron, I believe I heard you say that you've had scans, but they never revealed anything. Is that right?
Right.
What type of scans did you have?
I don't recall all of them. When I was first diagnosed, they gave me a bone scan. And more recently, I don't really recall the type of scans. But even the most sensitive scans, you got to have a PSA of like 0.2 or something to be eligible to get the scan.
Right.
So, my PSA, the chances of seeing cancer somewhere is probably pretty slim.
But that's right. So you were always treated very quickly after the PSA started rising. So you never really got anywhere near even 1.0. Is that right?
Yeah, the highest that got was 0.20.
Oh, yeah.
That was
Okay.
back end of 2007. And I'd have to go look it up. I don't remember if they did a scan before they radiated the local bed or not. But PSA one undetectable for 7.5 years. So chances were pretty good that whatever cancer could be seen probably was in that radiation field.
Okay.
And then this last occurrence, it only got to 0.06 before we jumped on it.
Did I hear John Appler before wanting to ask a question?
No, I would just like to welcome Ron. I lived near you in Los Altos, right on the border of Sunnyvale, and welcome to the group, Ron.
Oh, thank you. I eat at the same restaurant in Los Altos almost all the time.
The Bar and Grill?
It's well, I used to go there. Cafe Vitale. It's
Sure.
Foothill in Fremont.
Know it well. Welcome, Ron.
I've eaten there at least 400 times in the last 3 years.
Yeah. Good sign.
Okay, was that it? You're not going to fess up to where you live now, Mr. Appler?
Oh yeah, we're Ron. I now live in Maui, where I think we have one or two urologists, and they're primarily surfers. So with Peter's help and the help of Rick, they got me back to UCSF in my case, where there were some great docs there. So that's always a resource for you as well.
I envy you living in Hawaii.
Except for the medicine.
All right. Well,
If I ever retire, that'll be my goal, to live in Hawaii.
It's hard to beat.
Well, I have to tell you that the most impressive support group I've ever seen. I took the Caltrain down and then Uber over to El Camino 3 times, I think, when I was doing treatment. And to walk into that room and see all those guys around that big table with 3-inch binders and graphs and computers and stuff. I mean, they seem more prepared than my doctors have been.
You're talking about the advanced group that meets at 5 o'clock?
Yes.
Yeah, there's a lot of knowledge in that room. Yeah.
There is.
Although sometimes there are too many opinions too.
Right.
Okay, well, I think we should probably move on because we've got a lot of people on the call tonight, and I do want to get to Bill pretty quickly.
Before you go on, we have another caller. Would you like to identify yourself on the telephone?
Yeah, this is the San Francisco guy with the TSA of 653.
Jay Curran. Hello,
Okay.
Jay.
Okay.
How are you?
You're challenging my memory. That's not a good thing to do. Thank goodness Rick has a memory.
You know this is. This is. Okay, so let me just check and see how many people would like to talk tonight, and then we'll jump in with an update from Professor Bill. Jake, did you have anything?
No.
I thought you went to see your. You can't pull the wool over my eyes like that, Jake.
Yeah, I did. I have.
Okay.
Okay. Yes.
All right. Thank you.
Ugh.
Les, did you have anything?
Not tonight, thank you.
Thanks. Bill, for sure. Rich Jackson. Mr. Jackson, are you with us still?
No, I'm good, Rick. Thanks.
I would like to point out to you guys that we had, when was it? About 2-3 weeks ago, we had a session of Rich's Speaking Freely, our men-only all cancer group, where we spoke about language. As some of you may recall, we talked about it a little bit here too. And Howard Walensky was in the group, and he just today published an article on essentially the language of cancer, and we've bookmarked it. Funnily enough, Rich just pointed it out to me here in the chat window, just about the same time that John Novak from Inspire sent me a note and said, look, you've got Howard's gone ahead and published. So if you want to click on it in the chat window or go to MedPage Today, the article is called I Have Cancer, Please Don't Call Me a Survivor. Just pointing that out. Sylvester, anything for you today?
No, thank you.
Okay. Dennis, anything you'd like to bring up?
Yes, I'd like to give everybody an update on my latest annual scans.
Okay, super. John Appler, anything for you?
I'm good, Rick. Thanks.
Jim Ward, do you want to update us on how you're progressing?
Sure, I'd be happy to do that briefly, and then I do have a question for the group, just ahead of some radiation treatments. That's what I've got.
Okay, super. Ken, anything that you'd like to raise today?
No, I'm good, thanks.
Okay, Paul Frieder, anything for you?
Nothing for me tonight, thanks.
Okay, Peter Kafka, anything for you?
No, I'll pass.
Okay, Carl, is there anything you'd like to talk about today, especially since you have Professor Bill on the phone?
Oh, well, I was just going to say I defer my time to Professor Bill. I'm anxious to hear from him.
Okay, okay. Larry Fish, anything for you?
No, I'm okay for tonight. Thank you.
Okay, Len, anything you'd like to talk about?
Nothing, Rick.
Okay, Jeff Dreyer, I'm so glad you found us at the right time. Anything you'd like to talk about?
Thanks. No, just listening in. Thank you.
Okay. Bill Franklin, anything for you?
No, and I'm glad I picked the right time tonight also. I'm just listening. I'm actually working while I'm listening, but if I can pipe in on something, I will.
Okay, of course. And Jay Curran, I think you need to give us an update if I'm not mistaken.
Okay, and then I got two questions.
Okay, so let's go to Bill first of all, and Bill, give us your give the guys an update on all the things that are going on with you since you last spoke to us.
Okay, I'll try to make this as quick as possible. Let me first start by saying that I don't live in Hawaii. I live in the opposite end of the spectrum of weather in Buffalo, where it actually snowed today. And but there also was an article in the New York Times this morning about how Buffalo and Duluth, Minnesota are among the best cities to move to if you're being impacted by global warming. Things will actually improve in these places rather than get worse. Okay, so just a brief, description of how I got going with cancer. For those of you that haven't heard it before, I was diagnosed in April of 2013, almost exactly 6 years to the day, by my colleagues at Roswell Park, where I'm a cancer scientist, as Rick mentioned. I was diagnosed with a very large Gleason 9 tumor. I was not metastatic at diagnosis, but I became metastatic within 4 months after radiation therapy, which was the primary treatment that I went through. And prognostically, that's not good. That you convert that quickly. I had an extensive family history of cancer. My father had prostate cancer. My younger brother was diagnosed with prostate cancer at 41. My mother died of early onset breast cancer, and every single one of her 5 siblings died of cancer as well. And all of these cancers were ones that are associated with mutation in BRCA genes. And so I was tested later on in 2013. The test I used was Ambry, and I highly recommend it. It's in part because they provide such a thorough description of the information that you need to know if you test positive. So the test revealed that, in fact, I had a pathogenic mutation in the BRCA2 gene. And at that point, I asked my oncologist, who knew nothing about the genetics of prostate cancer. BRCA mutations are associated with prostate cancer. Very few oncologists actually know this. I think more are beginning to learn it, but it's still not something that's well known. And it's only, it's a few percent of cases that are driven by these mutations, which is why I think it's not known, but that's worth keeping in mind. So anyway, I asked my oncologist to put me on a PARP inhibitor that would target that mutation. And that it was a first generation inhibitor that I mentioned before called olaparib. In fact, if you are interested in the details of the story at this point, if you do a search on my last name at the New York Times, there's a short article about this and that will come up. It was published in 2015. So I have also been treated at Dana-Farber Cancer Institute in Boston. I was in a clinical trial there last summer that involved testing a drug that targets a genetic pathway my lab discovered 15 years earlier. It was an inhibitor of a protein called ATR. This is a DNA damage response protein that's involved in maintaining genetic stability. And unfortunately, it really didn't do a good job. It slowed things down, but it didn't stop things. And so I withdrew from the trial in last fall. Shortly after I withdrew, I had some tumor DNA that was biopsied from a positive lymph node sequenced. The DNA was, genetic material was sequenced at Dana-Farber. And among other things, it revealed that the BRCA2 mutation. So I need to say that after the olaparib bought me 2 years, my PSA went way down and stayed down, but then it began to climb again. The olaparib was no longer working, and the tumor sequencing last fall indicated that the reason why is because the BRCA mutation in my tumor cells had done something called revert to the wild type, meaning the mutation no longer had the effect that it did. This is something that rarely happens, but I got unlucky and it happened to me because now I no longer had the ability to use drugs like PARP inhibitors. So later on in the fall, I switched to docetaxel, and that was quite effective. My PSA dropped significantly from about 60 to about 29, I think. Rick probably has the numbers there, but it's something like that. So that was with docetaxel, but then it quickly began to go back up again. I then had one round of pembrolizumab or Keytruda immunotherapy, which is something that used to be considered not, it doesn't work very well a lot of the time with prostate cancer patients unless they had mutations in DNA repair pathways. And then it does tend to work more frequently. So it's something that, if you fall into that category, is worth considering. There was some indication earlier last year, I had a couple of rounds of pembrolizumab and it looked like it might work, but then I went into the clinical trial instead. But this time when I had it in February, this past February, it really didn't do anything. So at that point, I should just quickly mention that I was in Vermont visiting my brother, and after treatment at Dana-Farber in Boston, and I decided to ski down my brother's set of stairs backwards on my back. And that caused, I was really, really lucky. I broke my left scapula, but that was the only fracture. My spine, thank God, was not damaged. But that has slowed me down quite a bit in terms of activity. I had at that point a CT scan that was designed to look for damage from the fall, and that revealed that I had a thrombus, a blood clot, in my vena cava. And so this is not good. I've been, since then, I've been on an injectable anticoagulant called Lovenox to try to dissolve the clot. And I don't know yet. Well, I'll find out later on this week whether or not that's working. I then was treated with cabazitaxel, a drug that's in the same class as docetaxel. It's they destabilize the same proteins in tumor cells. And that worked really well. It knocked my PSA gone up to about 229, and in 3 weeks, it knocked it down to 130. Unfortunately, I didn't know that when I went for my next infusion 3 weeks later. And my oncologist and I decided to use a combination of cabazitaxel and carboplatin. And now, knowing how well the cabazitaxel worked, we think we should have just stuck with the cabazitaxel. I got hammered by those two drugs together. I became extremely neutropenic, meaning my white blood cell counts were in the toilet. And that eventually led to my hospitalization this past week in a room at Roswell with a giant HEPA filter to filter the air to protect me. I don't know. I had another blood draw today, and I don't know yet whether my white blood cells are going back up again, but the expectation is that they will go up soon. So I also was treated with a drug called Neulasta, another one that you hear about on the TV all the time. And this is a drug that is supposed to boost the production of white blood cells. And it's an injectable drug. It's a strange way to be treated because the drug comes from a device that is attached to your abdomen, and it has 4 needles for the injection and a timer that injects the drug exactly 27 hours after the chemotherapy infusion. And then you pop the thing off and throw it away. About 20% of patients that are treated with Neulasta have a really bad reaction where because it's stimulating the production of white blood cells and bone marrow so quickly, it causes a huge amount of pain. And that happened to me last weekend. I was in just utter agony for 3 days. And I had to go into Roswell for pain management. They put me on Dilaudid, and that helped somewhat, but I still was in a lot of pain. This is something that anybody that's considering Neulasta treatment should know about. There are lots of reports on the web from other patients that have had similar reactions, but it's worth keeping in mind that it's only 20% of the patients that are treated with it. And if it works and doesn't cause you pain, it's extraordinarily helpful, at maintaining levels of white blood cells, which is really important. So, it's something that you really need to talk to your oncologist about, but be aware if you do have those discussions that it can have this effect. So, I was in the hospital I was admitted on Tuesday, and I've been hanging out in this room with a HEPA filter until Saturday. And I was discharged on Saturday with some reservations on the part of the doctors because my white blood cells are still pretty low. But I have a daughter who travels around the world all the time, and she was visiting for a short period of time, and I wanted to hang out with her. So I convinced them to let me out. And then while I was in the hospital last week, I had an MRI of my spine that detected one metastatic lesion in the thorax region that is beginning to impinge on my spinal cord. And so it hasn't caused any problems yet, but the decision was that we needed to get rid of it as quickly as possible. And so this morning I went back to Roswell and had a radiation simulation, and then I had my first radiation treatment at noon, and I think it went pretty well. I'm a little bit sore, in my back, but I'm, what the radiation oncologists have told me is that getting rid of this lesion and a couple others nearby on my spine should make it possible to return to the level of mobility that I had in the past. mean, I'm not, I can walk and, I'm not in a wheelchair or anything, but I'm a really avid hiker, and I'm hoping that this will make it possible to go back to that this summer. So that's my story up to this point. Um, uh, I'm trying to think if there's anything that I left out, but I don't think so. So if anybody has any questions, I'd be happy to answer them.
Yeah, I have a couple
Only
questions,
Bill.
Bill.
Hold on one second. Bill, only the fact that you are waiting on lutetium.
Oh yeah, thanks. Yep, I forgot. So I'm in frequent contact with my oncologist at Dana-Farber, who is going to get me into a lutetium-177 trial. So this is a radionuclide treatment where the lutetium-177 is a isotope that is attached to a protein called PSMA that's on the surface of tumor cells, and so the idea is that once they attach to tumor cells, and they only attach to tumor cells, then the radiation will blast them and kill them. It's turning out to be pretty effective in clinical trials, and I think it's likely to become part of the standard armamentarium for advanced cancer. The trial, unfortunately, that will open up at Dana-Farber very soon will randomize patients 50-50 into the lutetium arm or an arm that will involve standard of care. So, my odds are only 50-50 that I'll get into the lutetium arm, and so that's not good. And Rick has been helping me to find a different trial where the possibility of getting into the lutetium arm is going to be higher.
Okay. Okay. So, was it you, Ron, that had a question?
No, I think it was me,
I would
Rick.
just say that I would be happy to answer questions not about my case, too, if anybody has questions that are related, that they think that I might be able to answer.
Okay. Jake, let's start with you.
I believe Ron Boucher has left. He left us a
Yeah,
note
I
in the
see
chat
that.
box.
Yeah, I see that.
Sorry to hear you going through all this, this crap, Bill.
Yeah, thanks, Jake. It's not.
You're a braver man than me, I'll tell you that. I do have a question, though, or two questions, actually. Number one, the blood clot, do they know what caused that? Was it from the medication?
No, it's this is something that everybody should know too. Cancer patients are at a high risk for blood clots. I'm not sure why that's the case, but it's a general phenomena for all cancer patients.
No, that's reassuring.
Yeah,
Something I asked.
yeah. So I mean, another thing to talk to your oncologist about if you have advanced cancer. But I don't, I'm not sure what that means. I don't know what the increased risk is, and it may not be that big.
It seems
No,
to
that
be.
happened to me too, about halfway through my my chemo regimen. My white blood cells crashed and ended up in a hospital for 5 days with multiple pulmonary embolisms, both lungs,
Oh,
and
wow.
pneumonia on top of it.
Oh,
But
that's horrible.
that stuff is treatable. It wasn't comfortable, but it was treatable. And I had to do the Lovenox also for a period of time, even after I got out of the hospital. That was not really comfortable to do. It's an injection, you self-inject into the your
Yeah,
love handles, actually, the sides around your abdomen.
yeah.
But finally, and there is a test. to determine when those blood clots are gone. There's a blood test, a very simple blood test that they do. So after several months, they did it for me, and it appeared that there was what they called debris was gone from the blood, which meant they were completely dissolved, and I didn't have to continue with any blood thinners at that point in time.
Okay, that's good to hear. And I'm going to ask, I don't know about this test, but I'll ask about it.
Yeah, and they did tell me the same thing, that the cancer itself can cause these blood clots, but they also said the docetaxel could possibly cause it too.
Okay, that's good to know too. I have not heard that.
But they
Dennis,
they can't make the distinction.
Dennis,
between
didn't you have some issues with the Neulasta as well?
Well, that's when I went on Neulasta. After that stint in the hospital, they reduced the rest of my doses of the docetaxel by 20% and added the day after shot Neulasta for the rest of my regimen.
Okay. Somebody
that
that
was my second question, Bill. Did anybody talk to you about using an antihistamine like Claritin with the Neulasta?
Yes, and I did use it, and it didn't help much.
Okay, I'm sorry to hear that. So what are they going to do the next time you have cabazitaxel?
I don't know yet. My oncologist visited me in the hospital on Saturday before I was discharged, and we talked about lowering the dose, and but I'm thinking I need to get another PSA measurement to see where things are at. That will happen on Thursday, and I'll meet with him again at that point. And I think that at a minimum, I'm going to tell him that I can't do Neulasta again. It just was too horrible. I don't know what, it's tricky. I mean, I need those white blood cells to be up. And certainly I won't have any infusions until they get back up again.
Right.
So, Jake, I want to point out, though, that Bill didn't have a bad reaction to cabazitaxel alone. He had a bad reaction to cabazitaxel and carboplatin.
Carboplatin, right.
Hey, Bill, it's Larry Fish. I know we've discussed this in the past, but what my oncologist, what we did with the infusions with the Neulasta was prednisone, dexamethasone. It was pretty helpful because I was suffering from a lot of pain, and that shot helped. And I even used to get pills to taper down between chemo treatments. Did they discuss that with you as possible? I know it's probably scary to take another Neulasta shot if you really got that pain.
Yeah, no, it was after the chemotherapy infusion, they put me on oral dexamethasone.
Dude, there's dexamethasone infusion too.
Yeah, I know. Yeah, my wife is reminding me of something. But then, so, and there's also, my wife just reminded me that there was actually dexamethasone in when I received the infusion, it was included of the chemotherapy.
Yeah. Okay. Yeah, that's the pathway I followed. Okay.
Right.
Sorry.
And then when I was in the hospital this past week, they also were, pumping me up with it through my IV. And now that I'm home, I'm back on oral dexamethasone. And it helps. There definitely was an improvement in the pain level after each time that they put the dexamethasone into my IV.
Bill, you're amazing. You're amazing what you're going through. I'm in awe. I can't believe what you're going through. Do you still have the pain pump working?
Yes. Yeah.
It's not enough to control the pain. You've got to take things in addition.
Yeah, the pain pump only addresses pain in the pelvic region, and that was caused by radiation cystitis. Because of the BRCA mutation, every cell in my body is more sensitive to radiation than normal people. And so when I went through radiation treatment back in 2013, I think it caused more collateral damage than usually is the case. So I have what's called an intrathecal pain pump that's implanted underneath my skin and has a catheter that runs into the intrathecal space of my spine. So, the pump needs to be refilled every 5 weeks, and it pumps in hydromorphone or Dilaudid and a drug called bupivacaine, another one called clonidine. And the idea here is that you can treat pain with these pumps in a very defined, rather than systemic way. So I don't need to worry about, a systemic reaction to the drugs.
Is Carl Foreman, do you have any questions?
Gee, I don't know. I could ask 100 questions, but I just finished my Provenge treatment bill on Friday.
Okay.
My sixth treatment, I guess, 6 of 6. And there is a bit of nausea there. Tonight you didn't discuss, I'm not sure if you have in the past, but basically improving your bone strength. I've been on Extiva, and I didn't recall whether you had said you had been on that, whether you needed that.
No, I haven't been. It's complicated. That bisphosphonates can cause a really awful problem with basically they can dissolve the bone in your jaws. And I'm very afraid of that happening. So I have not agreed to be treated with bisphosphonates.
Well, but Bill, the denosumab is actually not a bisphosphonate. I don't know what class it's in, but it does the same. It works the same way as the Zometa, as the bisphosphonate, but it isn't in itself a bisphosphonate.
Okay, how do you spell it?
The generic name is denosumab, DENOSUMAB, and the commercial name is Exgiva. It's the same as Prolia. It's just the Prolia is a shot that lasts for longer than the Exgiva. I think it's a different dosage, to be honest, is what it is.
Yeah, okay. I will dig out information. I mean, I should know these things. It's just that there's so much going on that.
Bill, unfortunately, it has the same incidence of ONJ that the bisphosphonates have. So.
Oh, okay.
That's your concern. It's not going to alleviate your concern when you read up on it. You'll see.
Yeah.
That's also one of the reasons that my oncologist decided not to give it to me every 30 days, as is, I believe, usually the dosage, but he's expanded that to 90 days instead of every 30. But I'm sorry, every 45 days. 45 days.
Okay, that's something that my oncologist has offered to do as well, to actually stretch it out even more than that. But I'm just, I just haven't been able to screw up enough courage to do it.
Bill, I've been on Zometa for what?
I was going to go to Len, but go ahead, finish. Since you're talking about
Len.
Go ahead.
Forgive me, I'm sorry.
Just very quickly, I just wanted to let Bill know that from what I've heard, that bone pain reaction to Neupogen is typically only happening on the first injection, and that it doesn't happen subsequently. But read up on that too before you decide not to have another injection. I think that's the case.
Yes, my wife Deb just who's listening, just made the same point after you did. She's read that too. So we will look that up.
Yep. Okay.
Jake?
Go ahead.
I was just going to comment about the bisphosphonates, Zometa. I think Prolia is also a bisphosphonate. I don't think it's the same as Xgeva, Rick. But anyway, Bill.
Prolia and Xgeva are the same drug.
They are the same. Okay. I thought Prolia was bisphosphonate. Anyway, the incidence of O&J is relatively small. There is a possibility, and it certainly does occur, but is a relatively small percentage of people who are on it.
Yeah.
And so the
I'm
benefits
aware.
a lot of times outweigh the risks.
Yeah, I'm aware of that. And, I've had a problem for quite a while of it's difficult to open my mouth wide, and I'm worried that reflects, some sort of a chronic infection. So I need to go to a dentist too and get that squared away. But yeah, I mean, that's really the big reason why I've been afraid to go forward with this.
Well, if you decide to do it, they do recommend getting a dental examination before you start.
Right. Yeah. No,
Which I did not do, but you should do.
Yeah, for sure. Yeah. Especially because I've had this problem.
Yeah.
Let me just also interject that I saw a report in the science literature last week about a new drug that strengthens bones that was just approved for breast cancer patients. And it does not involve bisphosphonates and does not cause these problems. So I've already talked to Kamal Chadha, my oncologist, about perhaps getting hold of that drug. So we'll see.
Okay, well, I think unless there's anything very urgent, can speak or forever hold thy peace. Otherwise, we will move along to Mr. Correa.
Hello. I have one quick question.
Go ahead,
Bill.
Jeff.
Yeah. So in 2013, you had, I guess, IMRT, and then now you're having radiation to the spinal area. And
Right.
I'm just wondering, at what point is there concern about overdoing your lifetime dosage?
I don't think
radiation?
that's a concern. I think I would have to get a lot more radiation to get to that point. I mean, I was concerned about the fact that I'm, still neutropenic, and radiation can contribute to that. But what these guys told me this morning was that the amount of, that the amount of neutropenia caused by radiation depends on how much bone marrow gets irradiated. So it's more of an issue if you have to have whole body radiation. But if it's limited to just a couple of, places in the bone, it's not going to contribute enough to make a difference to the
Okay. Okay.
Jeff, just to clarify, typically spot radiation, which usually involves anywhere from 2 or 3 to 5 or 6 sessions. I mean, occasionally more, but that's probably a good average. It can be repeated around the body if necessary after IMRT. I have never encountered anyone that has been refused spot radiation after they've done IMRT. I think in particular of somebody like Eric Bookbinder, God rest his soul, who must have had 4 or 5 different sessions of spot radiation. It's that I don't think. Now, what they cannot do is they can't radiate an area that's already been radiated.
Oh, okay.
Yeah, that's a good point. Yeah, and that's so the radiation treatment that I'm receiving now, of course, is not anywhere close to the prostatic region.
Okay. Yeah. Thanks. Yeah.
Sure. All right, let's move on to Dennis and Dennis, let's get an update on those scans.
Can I interrupt just one more time?
Sure.
So at this point, I think I'm going to have to cut out, guys. So.
Okay. Well, thanks.
Take care, Bill.
hanging
Take care.
Take care, Bill.
Thank
Good
you.
luck to you, Bill.
Thanks. Good night, everybody.
Thanks for hanging in. Hi, say hi to Deb, or hi, Deb, and I'll talk to you soon.
Okay, Deb is right here.
Hi, Rick.
Hi.
All right. Good night, everybody.
And somebody just joined us on the telephone. Who might that be?
That's my name's Andy.
Okay, Andy. And have you been with us before?
This is my first time talking to you guys.
Okay. Well, normally we receive first-time callers and give them priority. I don't think we can do that today because we're so far into the call, but we would love for you to come back next week, next Tuesday, and we will promise to put you on first. If we have time when we're done, we'll come back to you. But we have been going now already an hour and 15 minutes, and we've got a bunch of the regular guys to get around. So I hope you'll forgive us for that.
Well, let me ask you this: if I just stay on and listen, is that fine?
That is more than fine. And what I see you came in on the phone. If you would be good enough, if you're comfortable, you can give it to me online, or otherwise, if you'd be good enough to email me your email address, we'll add you to the distribution, and you'll get a note before the meeting starts, just a reminder before the meeting starts. It goes out about 2 days before. This week I was a little late for certain reasons. But, whatever's most comfortable for you, or you can.
I lost you.
Oh, sorry. If you give us your email, if you let me have your email either over the phone right now, or you can email it to me at rd@ancan.org, rd@ancan Alpha Nancy Charlie Alpha Nancy.org.
Why don't we do this?
Yeah.
I don't want to hold up with whatever's going on right now. I just thought I was calling just to talk to one person. But if I listen to what's going on, I might know if I need to continue on with you guys or not.
Okay. The other thing is, feel free to give me a call after the meeting. My number is 415-505-0924.
0924.
Right.
Okay, and you're Kurt.
I'm Rick, R-I-C-K.
Okay, Rick.
Okay. Dennis.
Okay.
You the man.
Alrighty. Just a quick background for everybody. My diagnosis was back in early of 2016. At that time, it was just out of the blue. My PSA had gone out of range, and subsequently to that, went through the prostate biopsy and came out with a Gleason 9 score, and was told I had a very aggressive form of the disease. And then I spent some time and find the right doc to go to, which I did, and started right out. Hit me hard with docetaxel and Firmagon. That was my first introduction. I had already I had, I believe, was 5 metastases to the bone, plus lymph node activity in the abdomen. And I got through the docetaxel chemo pretty good, other than a short stay in the hospital. I think I mentioned that earlier. And got out, and I got a pretty good response out of that. Got my PSA down really low, but then had a subsequently started to come back up again, and time for the second line anti-androgens is about a year or so. And that brought me, I started with, switched from Firmagon to Lupron and Zytiga. And that brought me back down again to, let's see, about in August of 16, down to 0.66. No, wait a minute. That's before, then it went up. That's after the chemo, down to 0.66. Then went up in 2017 to over 2. And that's when I started the second line anti-androgens of Zytiga with prednisone. And I'm, in addition, I'm still on the 90-day Lupron injection and the 1,000 milligrams Zytiga with 2.5 milligrams prednisone twice a day. That brought me way down to less than, eventually to less than 0.1 on my PSA. And all this time, I have an oncologist at Mayo Clinic in Scottsdale, Phoenix, and I also have another oncologist locally here in Tucson. And it worked out that the two of them are good friends, and they see each other periodically and discuss my situation. But I get my Lupron injections locally, and get my blood work done locally here, which is really good. And then I was seeing my oncologist, my main oncologist at Mayo, every 6 months and getting scanned once a year. So this past week, I just got my whole body nuclear medicine bone scan and CTs of the pelvis and the chest. Yeah, CTs of the chest and the pelvis. And it's, it's a stressful time when you get ready to go for these things. You don't know what they're going to find and so on. But let's get it on and let's do it and get through it, which I did. The CTs came back showing a very much decreased sclerosis of several metastases in the spine and pelvis, and a few had previously noted metastasis in the central sacrum are no longer apparent. So that was good news. And then the bone scan came back, and the quote here is from the report: the only remaining visible site of uptake related to known metastatic disease involves the proximal right femur at the base of the femoral neck. And however, this has decreased in intensity since the previous exam. All other lesions have scintigraphically disappeared.
Wow.
So I'm feeling really, really
Wow.
good and grateful for, and I think it's the Zytiga and the prednisone is just, for me anyway, and I don't know how many other people, it's got side effects to it, but you kind of, you get used to them, I guess, after a while. So, the hot flashes and stuff like that, the fatigue. And I know I got to keep moving and I keep golfing and doing other stuff. So if I can keep doing this, and my main guy up at Mayo says, well, I'll see you in a year. So I don't need to do a 6-month thing with him anymore. So I'm on a frequency
Oh
of
my goodness.
once a year. So just
That's
feeling,
great
and
news,
again, my
Dennis.
PSA is still at less than 0.1. And so I got to keep doing this stuff, and I will do it. And as I've said before, you know, it's not a survivor or whatever it is. I've got cancer, but I'm going to live with my cancer for as long as I can. And I just whatever it's going to take. I know factually, eventually, the Zytiga is not going to work at a certain point in time, or it's going to have an adverse effect on some of my other organs, which they also did tests on. Just prior to my having the scans done, I was starting to have some heartbeat skips and talked to the doc about it. And he says, you should go get a full echo stress cardiogram. And so I went and made an appointment to a cardiologist, and he examined me. He said, first of all, I want you to wear this monitor for 2 weeks, which puts on your chest, and it's got it looks like a smartphone that records and sends the signals from your heartbeat. I did that for 2 weeks, and then I got a call from him. He said, yeah, you got a little skip there, but it's nothing that needs to be treated at this point in time. And then they scheduled the full stress echo, which I was wondering whether or not I'd be able to keep up with that treadmill increasing in speed and elevation. And I did. I got through the whole thing. And then they called back on that, and it said everything was good. So and then when I got up for my scans, you know, all that information was forwarded to my main oncologist up there, and they also did a liver function, kidney function just before I got my scans because of the injections that I had to have. They wanted to make sure my kidneys and liver were up to snuff to handle that stuff, and they were. So that was so doubly good news that at this point my organs are not adversely impacted by it, and the results are great.
Fantastic. That's wonderful news.
I mean, that's so there's hope, I think, for everybody. The other thing I could mention for those of you that are kind of hearing my story for the first time, I still have my prostate. And the other note in my CT exam was that, oh, geez, I can find it now. But there's something about the prostate lesion is significantly, let's see, can't find it, but it sounds like the prostate is smaller now, and there's just I don't know how to put it, but something about the primary tumor there.
Let me ask you a question, Dennis. Did you have any discussion with Dr. Singh about how long you would remain on the Zytiga and also about the LHRH drug?
Indefinitely.
Indefinitely, okay.
Yeah, yeah.
Okay.
Now we'll keep getting out of this whatever we can for as long as we can. As you know, I'm able to put up with the drugs and the side effects and that type of thing. So we'll just keep working it.
Fantastic. And how's your golf game been this week?
Well, today they awarded me my certificate of achievement for championship and my match play tournament we had. That was like from over a month and a half, 2 months ago now. We had our match play series. You had to play, you know, hole by hole match play, and you knock one person off, then you move up to the next bracket, and you knock another one off.
Maybe Trump will give you a Medal of Honor.
Hey,
I don't think I want one from him.
I don't know, but, you know, if I were Tiger, I'd be looking over his shoulder.
Well, the other thing we did here, my wife and I, we you know, we're in a car club here locally, and we had an excursion to Santa Barbara, California, and the opportunity to go up there and stay at a very nice resort. We drove my sports car all the way through the mountain roads and so forth up there, Santa Barbara. The Pacific Coast Highway. This is all new. I've never been there before. I mean, you guys are in California, might take it for granted. I just thought it was spectacular. We had a
Yeah, it is.
fantastic
Yeah,
time.
yeah. Oh, yeah. All right. Well, that's great news. Anybody want to talk to Dennis?
I'm curious about the any need for a PSA testing for before a year from now.
Yeah, I get that PSA tested every 3 months. I get
Ah,
locally, I get my blood work done every 3 months here, get my 90-day Lupron injection, and my PSA. Oh, my
and
cholesterol is also way down too. What's that?
before Zytiga, you were on what?
Before Zytiga, it was just the I'd done chemo with docetaxel and started with Firmagon, and then we switched to Firmagon to Lupron, and then I'd had that reoccurrence. The PSA started rising, and that's when we went up and we did the Axeman scan, flucyclidine, I believe was what they used. Yeah, that's when they found the reason for the slight rise in my well, it was actually it doubled from a pretty low level fairly quickly. And I had new metastases to the pelvic area and the left femur. I'd already had one in the right femur, but so that's when we immediately went on to Zytiga.
And no other bone enhancing medication?
No. No
Oh, great.
radiation, no surgery.
That's great. Thanks.
So I know this is everybody's different with this, and what works for one person isn't necessarily for another, but I'd certainly like to share my story.
Good deal.
Great news. Very, very, very good. Okay. Anyone else like to ask Dennis any questions?
Yeah, Dennis, when you had the Axeman scan, what was the level of your PSA?
Oh, let's see if I can figure this out. It had gone to points
2.10.
2.1. 2.1.
Okay.
Yep.
Well, keep up the good work.
Well, Zytiga keeps up the good work. I'm just taking it. Swallow it.
I am going to feed your information back to my friends at Janssen because they love to.
We lost you there, Rick.
I said I am going to feed your success back to my friends at Janssen because they love to hear these stories. If that's okay by you.
Yeah, that's fine. I mean,
Thank you.
I'm 73 going on 84, but I'm still going.
I would not agree with that, but it's a matter of opinion. So, those 84-year-olds, they find it a little harder to get those certificates you got today and to drive their Carrera through the mountains.
Yeah.
Okay, so let's move along. Let's go to Jim Ward, who you say you're starting some radiation tomorrow, Jim.
Oh, not tomorrow.
Okay.
Coming up in early June. So this may or may not be something that's kind of premature to bring up to the group, but and obviously you guys can tell me, this is something we should talk about later. But since Rick, you asked for the update, the brief update is I started Zytiga and prednisone back on March 10th. My PSA tested at 2.9. on March 26th, and so that would have been about 10 weeks after starting the Lupron. And so it's been dropping from a high of 272 back in late December before I began the Lupron, and in mid-February it had dropped from 272 to 13.49, and then since between February 11 and March 26th it went down from 13.49 to 2.9. So that's kind of what's going on with that. And obviously the hope is that it'll drop further. In the meantime, just one quick note on the genetic testing. I don't know whether this is good news or bad news, frankly, but so I had the Cambry test done. I had the full panel of 75 genes tested, and it all came back completely negative. I haven't seen the report yet because it's on its way to me, but the genetic counselor who kind of set me up with that test, she reported to me that was the result. So, I guess I can't tie this to any particular, cancer gene, and I don't know whether that's a good thing or a bad thing. I mean, but
well,
anyway,
I'll just make one quick comment on that, which is that what it tells you is you haven't inherited any mutation. What we don't know is whether your tumor has made its own mutations, and for the time being, I don't think we really need to look whether it has or it has. At least if it were me, I wouldn't be too concerned about looking if it has or it hasn't, because I'm responding well to the Zytiga. But down the road, it still isn't going to stop you doing a test of your tumor to see if any of these precision drugs might be appropriate for you.
Right, and I think the test that you may be talking about, Rick, is having that biopsy or that core sent off to Boston where they do.
Correct.
Okay. Yeah. So we just one little note on that. I know it's an expensive test, I guess, but we kind of decided to hold off sending it off, for at least a year. I don't know if that's a good idea or not, but I guess the thinking was, as long as I'm responding for the time being, there's no urgency to send it away, especially because I guess the turnaround on the testing is much faster now.
It's about 2.5 weeks, but I can always intervene on any one of our guys' behalf, because I do have a little bit of pull at FMI. So, but I think I would absolutely agree. There's no good reason to test right now. And by the way, from a cost standpoint, there are a lot of options, and most people who are under Medicare age do not pay too much in terms of copays. There are ways that FMI is able to fund copays. So I wouldn't be too concerned about that right now either.
Okay. All right. Well, thank you for that. Well, I guess to kind of cut to the chase. So on the radiation anyway, because that was kind of my original question. Is in mid-May I'm scheduled for a CT of the abdomen pelvis, and then the next day I kind of review the results with my radiology oncologist at KU, and then I'm going to take the result of that scan and I'm going to visit with a radiology oncologist at MD Anderson that Dr. Korn is hooking me up with, I guess essentially just to kind of get a second opinion, to kind of have an opportunity for them to confer with my radiology oncologist at the University of Kansas. But I guess, I know that you can only radiate one area one time, so I feel like we got to make sure we do this right, particularly because they're going to be not just radiating the prostate, but they're going to be radiating, some lymph nodes, and I guess I don't know. I guess it's just so there's a horizon out there. We've got about well, I don't know, a month and a half before all this stuff gets started. I guess I'm just trying to figure out, without being out that far, I'm just trying to figure out what is it I need to be thinking about, or what do I need to be, asking about or focused on to make sure that this is done right. I know that's kind of a broad question, but I just don't, it kind of scares me, and I don't really understand much what it's all about, other than it's sort of models the Stampede trial, and they say, hey, if you want to be aggressive, this is what you do.
Well, yes, we suspect that being in the lymph nodes is it's kind of a strange place, because there are some people that consider that metastatic, and there are some people that consider that to be non-metastatic. In my books, it's metastatic. I actually had this discussion with somebody, with Alan Edel, better known as Tall Alan, a couple of mornings ago. But once that disease is out the glands and into the pelvic lymph nodes, it's very hard to route it up and stop it going any further. And so, at the same time, some of the drug companies have found it useful not to consider it to be metastatic. So essentially, what we're talking about for you is debulking the primary tumor with radiation, which, as I'm sure you know, is what Ken Anderson did, but he did it a little later after chemotherapy. There isn't a lot to prepare for in terms of where they're going to radiate. There are some questions you may want to address. You may want to consider whether they're going to use the gel to protect your rectum, or one of the other methods that they now have to protect your rectum, because that's a very valid concern. Ironically, it wasn't available when I went through my treatment. At the same time, the guy that did my treatment doesn't like to use it. So I wish he would have done, but I think it would have been a fight with him at the time anyway. But I don't know. Ken Anderson, I know you and Jim have been in touch, but what words of wisdom do you expect of preparing for the radiation?
Well, hey, Jim. I think I'm all Rick. I don't know how Jerry Lucas. I think he's the guy that was my radiologist. I know the gel was around when I had my prostate radiated, and he didn't recommend it. And at the time, I didn't even know about it. So, what I know at the guy was probably pushed harder, because at the moment where my prostate has a little bit of activity, wasn't radiated well enough. I did go to the end with a video oncologist there, and they were all both on the same page. So I don't know. I mean, it's a pretty sketchy. I honestly, I don't know what questions to ask in regards to radiation. You pretty much have faith in the person that you've selected to do what they do. And I know MD Anderson does it all the time, and Jerry's been doing it for 30 years, so I trust it. So, one point, just want to make sure, Jim, that when you get your PSA, you also monitor how your testosterone goes along with your PSA.
So we're having a bit of a time hearing you, Ken. You're sort of cutting in and out. Sometimes you're so clear, and other times we get you and we lose you. Repeat that last question.
I'll make sure that when you get your PSA, to have a testosterone as well.
Yeah, I did. I did. The last reading, which I think was the same as the one before that, it was 15. I guess it's supposed to be below 50.
Yeah.
Yeah.
I think.
Yeah. Yeah.
Hey,
yeah,
on the
yeah.
spacer thing, the gel, I guess what the radiology oncologist told me is that he thought it was going to be, I don't know, maybe more challenging to use it, just because, well, I'm not sure I'm going to even be able to articulate it to be honest with you, but I think he said that maybe because he thinks that perhaps the cancer has also gone into the rectal lymph nodes. So I don't know. I'm going to definitely ask him about it. So I know this is kind of a broad, kind of clumsy question, but I just thought I'd throw it out.
Not broader clumsy at all. I think if you have something like this done, you ask all the questions that come to mind. And of course, we don't have the knowledge to know what questions to ask. That's why we have this group.
Right.
Yeah.
Look, the closer to the time, because we're talking out in June, we'll talk to you about some of the issues in terms of preparation. Keep in mind, but we can address those closer to June. But I don't think that there is. I don't think. Does anybody else on the call have any suggestions as to issues you might want to address regarding debulking the primary tube? Do we know if they're going to radiate the whole pelvic girdle and all of the lymph nodes in your pelvic girdle?
Yeah, I think that's the plan. And I guess there's kind of an open question as to. I guess they think they can even do the one that's bear with me. It's the lymph node that's a little further up, like close to the aorta, the retroperitoneal one. That at least they're thinking is that it's a kind of actually a pretty hardy vessel and fairly low risk of long-term damage. So I can't get a clear answer on whether that's one they're going to radiate or not. I think I can tell they're a little goosey about it, but I don't know. I don't know necessarily whether they're going to do that one or not.
Okay. Well, in the interest of...
One sec. Hey, are you meeting with Brian Anderson? You know who the guy is at MD Anderson you're meeting with, the radio oncologist?
I'm sorry, you were breaking up there. Is the question who am I meeting with?
Yeah, is his name Brian Anderson?
No, I think it's a female, Thompson. Thompson.
Okay.
Karen. Oh, excuse me, Hoffman. Karen Hoffman.
Okay.
Yeah. So, well, thank you, everyone. I appreciate it.
It's a pleasure, and come on back. Take some more time when you need it. Jay Karen, bring us up to date.
Yeah, my PSA dropped 100 points. I guess it was in about a week from one reading to the next. And I'm no longer having to do etoposide. That's over with. and so I'm on 400 milligrams of testosterone every 4 weeks, and then at the same time I get a Firmagon shot. So when the testosterone wears off, the Firmagon is keeping testosterone low.
Okay, so let's just clarify for these guys that that Jay is doing bipolar androgen therapy right now, because some of people listening might be a little confused with what you just said, Jay.
Okay.
So you're doing BAT, and you've been taking during the on cycle, you've been taking you've been taking testosterone, and then when you're taking the drugs, what drugs have you been taking? You mentioned etoposide, although you're not still taking it, and what else?
Just a Firmagon shot.
Okay. So no second line anti-androgen. So you've basically been going from doses of testosterone to doses of an LHRH drug.
Yeah.
Okay. And your PSA has dropped from around 1100 to 656.
Yeah.
And when do you next test?
I think on Wednesday.
Okay. Okay. So tell us your questions, and then we'll open it up to the gents on the call.
Okay. My doctor has said that this probably won't last forever, the decline in PSA, and he's okay with me, trying to scout around and try to find an LU 177 or an LU 617. And I was wondering, and I talked to Will Cornell today, and I was wondering if any of you knew any of the doctors there. They want to line me up with Dr. Anna Morelli, I think her name is. Does that ring a bell?
I don't know. I mean, the only doc I know there is Scott Tagawa. I mean,
Okay.
he's the main name at Weill Cornell, and I don't know of any of the other docs at Weill Cornell. Is their lutetium trial active right now? And
It seems to be. I need to go to the website if they got one, because the fact that I didn't do heavy chemo may disqualify me. They may want people to have done that.
well, I would recommend, and I'll try and look for it at some time in the next tonight or tomorrow or something. But I would recommend that you go to clinicaltrials.gov.
Okay. Yeah, I should do that.
And you search. Now, I've got a list which I downloaded and I sent to Professor Bill about 3 weeks ago. And I think I saved that list. And if I did, or if I can find the email, I'll forward that list on to you. But that's the best way, rather than messing around on the Weill Cornell site. You're going to find the trials there, and you'll see whether you're eligible or you're not eligible.
Okay. Second question. Go ahead.
I was going to say that, did you just call Weill Cornell and ask for an appointment and then see Dr. Anna Morelli?
More or less. I didn't even ask for an appointment. I was just trying to get information, but they wanted to sign me up. So I said, okay, I might have to cancel.
Well, I think that if you were going there, again, I'd need to look at all the names, but I think if you're going to Weill Cornell, you should try and get an appointment with.
How do you spell his name again, please?
I think it's Tegawa. Len, do you know?
Yeah, that's correct.
Okay.
Tagawa, Tagawa.
Okay. The next question is, I've been told that I have a suspicious nodule in one of my lungs, and that it has grown, I guess, in about 6 months from 6 millimeters to 9 millimeters. I don't know about the units, but it's grown. And I was wondering if anyone had experience with prostatic cancer going to the lungs.
I'm going to throw this open at the end, but I can tell you that we have a number of people that have had incidents of prostate cancer in their lungs. Jerry Deans, for sure. A guy who's been on and off the call and been reaching out to me recently called Jackie Moon. I think Rob had some incidents in his lungs. Usually, if it's prostate cancer, usually you see it fairly early on, but not always. I mean, it can metastasize later to the organs. I mean, a lot of guys like Jerry Deans, it's never showed up in his bones. It's always been in his soft tissue. I think the answer, the question that you've got to ask is, how do we establish that this is prostate cancer, or if it is? And if not, what is it? And in that regard, I would be going back to Agarwal and asking him at UCSF, what do we do to check if this lung nodule is benign or if it's malignant? And if it is malignant, how do we check what it is?
I'll see him on the 22nd, so I can do that.
Okay, and what's the last question? And then we'll put this out to everybody so they can answer.
That was it, but I'm sorry, Professor Bill's gone, but I did have a blood transfusion and it raised my hematocrit from 24 up to 32. And
yeah, he's actually gotten 2 units so far, and he's scheduled for 1 more.
Okay, and I did get in the last shot, and it worked okay for me.
Right.
That's it.
Okay, anybody have any thoughts on this lung nodule or any thoughts on lutetium trials for Jay?
Well, I would just comment, Jay, that from my recall, which may not be very good, all of the lutetium trials did seem to require chemotherapy, having failed chemotherapy at least 1 round, but you might be able to find one that doesn't have that requirement. The other question I wanted to ask you is the BAT therapy that you're undergoing right now, is that outside of a clinical trial or within?
Yeah, it's outside a trial.
Okay.
Jay, I've got a question about the BAT. What are the effects for the testosterone injection? Do you get a rush of energy, or I mean, what do you feel when they give you the testosterone boost?
Not really. If anything, the first time, I'm on my third round now. If anything, the first time, I feel less energy and less strength. But I'm doing better now.
Interesting.
What was your PSA when you started the BAT?
Well, it actually averages up around 1,300. And it may have been higher. My memory's not as good as before I started Lupron and Firmagon. But it may have been higher.
Okay. So what we've seen is that the BAT, and you started it when, in January?
Yeah, the 12th of January.
Okay. And so what we've seen is that the BAT has been quite effective and brought you down to 656 by middle of March.
Or April. This is April.
Sorry, middle of April. Yeah, beg your pardon, middle of April. Okay, because I think that's what the guys are kind of thinking, and that's what's going through their head. What impact has this had? And it's really halved your PSA over a period of about 3.5 months.
I'll get a better read on the scans after Wednesday.
Okay. So you're about to do some scans, and you've dropped.
We got a bone scan done about a week ago, and then forget the name of the other one, but it was for soft tissue.
Okay, CT scan. Okay, and then you did a couple of etoposide supplements along the way, but you're not doing that anymore.
Right.
No. Well, look, we're about 10 minutes over, and I see some of my guys are dropping like flies here. So I think probably they're telling me we have to hold up. Have to close up? Is there anybody that would like to ask Jay Curran anything about his bipolar androgen therapy or any other questions? Okay.
I'd have to say I'd love to hear as much about it as possible, but not tonight, guys.
Well, why don't you make a pitch to Jay to come into the call a little earlier, and we'll make sure we give him plenty of time, and you can ask him all the questions you want. Or I'm happy to connect you guys offline. Well,
No, I don't know that. I just think in general, I'm so interested in what's happening with BAT that I'll make that pitch that if Jay has a chance to get on another call and go into some details about his experience, it would be wonderful.
Okay. All right. So next call will be next Tuesday, the 23rd. Yep, Tuesday the 23rd. I wish everybody on the call a very happy Easter and a very good Pesach and a good Seder nights. This year, of course, is a remarkable year because Good Friday and first night Seder happened to coincide, which I guess is what happened at the time of the crucifixion. So for those of you holding a Seder, when you open the door for Elijah, watch out. We don't know who's going to walk in this year. Okay. All right, so I'll say goodnight to everybody, and I'll talk to you all soon. Bye.
Happy. Thank you. Good night.
Night.